remarkable talks from our worthy speakers. Today, that will be a small step forward to lead us to the empowerment of health systems through digitalization. We will appreciate if your cameras are on for this event. For this event, we will have our moderator, Mr. Derek, and I will introduce him after a welcome address by our Executive Director, COMSATS, Ambassador Dr. Nafis Zikriya. I will hand over the mic to Ambassador Nafis Zikriya. Sir, please.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and good afternoon. Distinguished speakers, respected worthy participants, ladies and gentlemen, on behalf of COMSATS Secretariat, I welcome you all to this webinar to Digital Health, the New Normal, Innovations and Acceptance in Africa. Exactly 2 years ago, a completely new challenge in the form of COVID-19 plagued the world, presenting challenges of unprecedented nature. The ensuing wave of economic and social crises, though seen as a catastrophic, verily led to the expansion of horizon of innovation in disruptive technologies that the world would not have otherwise experienced in such a short time frame. Adaptation, innovation, and integration of new technologies became inevitable in almost every walk of life, including education, commerce, or health. To a great extent, the successful global public health response during COVID-19 is attributed to technological innovations during the pandemic. Introduction of protective equipment, diagnostic kits, preventive vaccines, treatment equipment and apparatus, and many other innovations during the COVID-19 led to some of the manifestations of how the COVID challenge has been converted into opportunities. The innovative technology-driven responses were not limited to the global north. The developing countries in the south also took initiatives and introduced programs during the pandemic, especially in the healthcare industry. The African countries, including Ghana, Kenya, Rwanda, South Africa, Nigeria, and Uganda, were able to generate ideas and solutions, leading to many novel technological innovations. Now, according to a data presented by COVID-19 Innovation Hub, 5 African countries, Kenya, Uganda, Tanzania, Malawi, and Nigeria, stood among the top 10 in terms of COVID-19 recognized innovations. That included manufacturing of robots and autonomous drones, development of mobile applications, automatic ventilator, and chatbots, among others. And I have already mentioned some of the other innovations which were generally came to the fore as a matter of challenge being converted into an opportunity. I understand that experts in our webinar today would shed light on such innovations and their integration in the healthcare system and help envisage and explain future trends and trajectory. The worthy participants may agree that digital health emerged as an effective and sought-after innovative approach with potential to make the health system more efficient and sustainable for future crises. The economies which faced financial crunch or constraints also found adaptation to technological applications in healthcare compelling to ensure continuity and sustainability of the system in the larger interest of humanity. Today, many of these technologies have smoothly gelled with the global healthcare system with tangible gains in terms of accessibility, affordability, and quality healthcare. Ladies and gentlemen, the digital technologies in health systems fall in a wide range of spectrum. At one end of the spectrum, computations, artificial intelligence, and decision support systems have facilitated health community, accelerate the efficiency and outreach, while on the other end, telemedicine and telerobotic surgeries are providing direct benefits to the participants. COMSATS, as an international organization, intergovernmental organization, being the torchbearer of South-South cooperation for sustainable development, has also ventured into telehealth sector with a pilot project and acquired such expertise and success that it evinced Government of Pakistan's interest with the aim to benefit the rural communities of Pakistan. We are working on developing and establishing a comprehensive telehealth network of clinics for the Government of Pakistan. We are reaching out to the rural communities through doctors and specialists based at its telehealth resource center in Islamabad to treat minor and major illnesses that would otherwise were to remain in disadvantage due to non-availability of doctors in those far-flung areas. We are confident that it would be a valuable service for the communities in remote areas and could be replicated among other members of COMSATS. And this is where we would like the other members of the COMSAT to benefit from this expertise that the Secretariat has actually acquired. The organization, comprising of 27 member states, aims to promote South-South cooperation in the fields of science and technology through its 24 centers of excellence, which are a very solid base of resource for us that are relevant to the socio-economic development. Since its inception in 1994, COMSATS has contributed well to the sustainable development in the South, both at the regional and sub-regional levels, and continues to align its activities and actions with the sustainable development goals of the UN. We at COMSATS are committed to developing synergies with the governments in the South and beyond to help achieve sustainable development through science and technology. The network of centers of excellence in member states and the development of flagship projects of COMSATS are not only contributing to their country's socio-economic uplift, but also to COMSAT's efforts towards 2030 global agenda. Now, with the resolve to promote South-South cooperation in the field of science and technology, COMSATS has been rallying and aligning with individuals, organizations, and public office holders to advocate and promote the real benefits of digital advancements in health, especially in the post-COVID scenario. In one cognate activity in September 2020, the stakeholders from the South Asian member states gathered and shared the experiences of digital health in their respective countries. Such advocacy activities bring those working individuals or individually to a platform for showcasing and networking. This webinar also envisions IT-driven health applications in Africa and exploit the potential of digital health in the region and challenges that accompany. The speakers in the webinar, I'm sure, will also highlight the post-COVID changes in terms of strategy and policy level for the implementation of digital health in African countries. We look forward to hearing from them. COMSATS believe that adapting to the new normal calls for new approaches by the developing world to keep up with the COVID-led advancements in the digitalization of health. And COVID-led means that, as I mentioned to you about, COVID actually posed a challenge, and the international community, were smart enough to convert those challenges into opportunities. The joint publications based on indigenous researchers, and success stories, cooperation in policy and strategy sharing at governments and institution levels, trainings and capacity building for the application of digital technologies for health are some of the areas where collaboration among the developing countries is needed. I would like to end here by expressing my thanks to all the speakers who will be sharing their insight into this topic and congratulate the COMSATS team on holding this webinar. I wish you all a successful event, and I look forward to working very closely with all our partners and the institutions and deliver in tangible terms the benefits that the member states look forward to have from COMSATS. Thank you very much.
Thank you for your kind words. Now we will start our technical proceedings. I will start by introducing our moderator for today. Our moderator is Mr. Derek Mohin. He is the Unit Head Capacity Building and Collaboration Digital Health and Innovation Department, World Health Organization, Geneva, Switzerland. Mr. Derek, are you with us?
Thank you so much, Dr. Farid. I am with you. I can see and I can hear you.
Yes. Okay. So the proceedings of the technical session, over to you.
Thank you so much, Dr. Farid. And thank you so much, Honorable Executive Secretary, COMSATS, for the timely remark that have helped us to set the scene for this particular webinar session. And would join the Honorable Executive Director to thank the team at COMSATS for putting together such a robust set of speakers, and at the same time to thank the respected participants for spending time with us during the remainder of this time for the technical session. I'm your moderator, Derek Munene, and I would like to greet you in the typical virtual mode. Good morning, good afternoon, and good evening, depending on where you are. I would like to proceed before calling the speakers by sharing a few highlights and the objective of the technical session, and then we'll be introducing the speakers for this particular segment. As Dr. Farid rightly mentioned, we are governed by a global strategy on digital health, and this is an implementation of Objective 1 of that strategy, South-to-South collaboration, skills transfer, which is exactly what is part of the objectives of this particular session. There are also other objectives that will be tiptoeing, such as patient centricity, putting people first. And so as we look at the different discussion points that will emerge under the theme, digital health, the new normal, innovations and acceptance in Africa, we must recognize that Asia and Africa have a lot of commonalities, population-wise, infrastructure-wise, and also with respect to emerging adaptation of digital technologies and solutions, such as telehealth, for example. But information gathering has been the most attractive initial digital solution. We've seen several countries in Asia and in Africa adopt digital aggregation tools over the past 21 years. The progress hasn't been as rapid as one would expect. We see in COVID times that emerging needed urgent digital solutions have emerged, like telehealth and telemedicine, patient pacing apps like contact tracing. The new normal is indeed digital, and we recognize that now is the time for us to invest not only for pandemic responses currently, but really investing for the future to ensure that African health systems in Asia are robust, resilient, proactive, predictive, and also prescriptive. We recognize that to do this concerted effort on the part of all is actually needed, and cooperation, collaboration is key. In terms of the specific session that we'll be getting into, we have three objectives. The first, the distinguished speakers will be speaking to how accessing the post-pandemic developments in digital health and the potential to identify future trends and needs can be harnessed. Secondly, to discuss the issues and challenges faced by the digital health stakeholders and to analyze the future healthcare trends before and after COVID-19. Then the third objective would be to provide a platform to policymakers to share digital health related innovations in COVID-19 times. With me is a set of distinguished speakers and panelists that will help us unpackage this extremely important topic and to distill it in such a manner that we are able to draw lessons learned and also apply these particular lessons. I'll introduce the technical speakers at one go, and then I'll call them to the floor to provide the interventions. The first speaker, Professor Dr. Lydia Azioto, will be speaking to the topic of digital health in Africa, positioning a university in the discussion. The second speaker will be speaking to digital health policy in African countries, delivered by Mr. Ademiyi Daniel for Layan. The third speaker to be delivering on the topic, the evolution and future of digital health in Nigeria, will be delivered by Ms. Oniadomola Songunuo. Thereafter, we may have a speaker from South Africa, Dr. Vuma Magega, who will be speaking to digital health innovations and acceptance in South Africa, to be advised whether he joins. Then thereafter, we'll be listening from Ghana, digital health situation in Ghana, by Dr. Joanna Eva Dudu. Thereafter, we'll have an intervention from Dr. Suhel Chigutai, who will be speaking to the topic virtual disease management via clinical telemedicine in Africa, design of services, and etc. And then thereafter, we'll have Ms. Joanne Stella Nakimuli, who will be speaking to digital health scenarios in Uganda. And then lastly, but by all means not the least, we'll have Dr. Hamadou Dia, who will be speaking to us around digital health project in Mali. We'll have a segment for a Q&A, and so we encourage respected participants to stay on to the end, where we'll have an interactive session. Without further ado, we'll now proceed with the first distinguished panelist, Professor Dr. Lydia Azioto, who will be speaking to us on the topic digital health in Africa. And Dr. Azioto is Vice Chancellor at the University of Health and Allied Sciences in Ghana. Dr. Azioto, the virtual floor is now yours. Over to you.
Thank you very much, Derek, and thank you, Dr. Azima, and all the organizers for giving me this opportunity this morning. Just to say that I'll be dropping off along the line because currently we have a meeting of all vice chancellors in Ghana because we have some strike action of public universities in the country. So I'm supposed to be there at 9, but because I think this is very important to me, I am here to give my take on the issue on the ground, and then I would link up with Dr. Azima later to touch base on what other ideas are so we can work together. Joanna Dodu, it's nice to meet you. If you can pick my number on the screen and contact me later, I'll be glad. You has to be glad to work with you. So I am glad to be the first technical speaker, and I'm trying to situate a university for this discourse. I know that when we catch them young, when they are in training, they will forever be ours in the digital space. So I would look at brief issues on the concepts and end with specific cases of my university that I lead. So generally, like the two speakers said, we are looking at technology, we are looking at health, and we are looking at software, we are looking at hardware. We are looking at the field of health and our discourse. So for those who have not visited my country before, where is Ghana located? So you can see that we are located this side of the map, west of the map, West Africa. People refer to us as a gateway to Africa or to West Africa. I'm not too sure which one is correct, but the Ghana is here, and we are ready to work with all of you, and we invite you all to visit us anytime you have a space of time. So if we look at it in general, what are we talking about? We are talking about a population of more than 1 billion. We are looking at 54 countries. We are looking at a continent where the socioeconomic status, the professional mix across areas in terms of rural, urban areas are not, shall I say, equal. We are looking at a continent where those who are trained as specialists are very few. We are looking at a continent where it's difficult to assess certain communities. We are looking at a continent where our culture is very different and give us the burden to care for our family members, extended family members for that matter. So when we are talking about digital health, we have to have these things at the back of our minds. So if we look at this and we say, okay, is digital health, telehealth, whatever health, e-health you want to call it, is this really something that is necessary? Well, so now within the continent, you find that the use of internet, mobile phone, smartphones are increasing. We have also realized that many of our countries have extended electricity to rural areas. Some of the countries have specific funding for rural electrification. We are also having more hospitals rolling into e-health. So telehealth is picking up to some extent. I'm sure other speakers will give more meat to this. If we have care that I don't need to travel many hours to the hospital, then it will save costs because I don't need to pay transports and all the issues thereof. I think that it will increase access and make it easier for people if we use technology. I don't need to stick to some timing. It can be an evening consultation with my specialist online, early morning rather than, so the flexibility will be very, very increased. And it, of course, it will save time and of course also prevent spread of diseases. Now, within the space, you find bits and pieces. So I'm sure that other speakers can give more information on what is on the ground. But from my search, you find that in some hospitals, some communities, some countries, you find mobile health, electronic medical records, which is picking up very fast in most hospitals now. You find that wearable devices are increasing. Telemedicine, telehealth, a few bits and pieces here and there across the continent. Now, specifically for Ghana, we are looking at a population of a little over 30 million. We used to have 10 regions, now we have 16 administrative regions of the country. And of course, our time is GMT, so it's just a little over 9 a.m. Our people are generally seen as very friendly, have stable democracy for many years. And our current government is very, very much committed to digitization. But specifically, I am speaking from an area southeast of the country. That is where my university is located. And so whatever discussion that I am going to talk about, I just want you to know where this university is. And therefore, if there is something tele here, it's going to spread across all the other areas of the country. So where we are located as a university is very near to the border going to the Togoland, which is a French-speaking country. Ho has an airport, so you can fly from Accra to Ho for about 15, 20 minutes flight time. It's a very peaceful region, clean, and a tourist attraction because the region has the highest mountain in the country, the largest man-made bridge lake in the country, and a monkey sanctuary, whatever. It has a lot of tourist attractions. So that part of the country, most people visit when they visit Ghana. And of course, once again, if you visit Ghana, you need to come to my region or where I find myself. So why am I bringing a university into the discourse of digital health? Within the space, the country, we have about 15, 16 public universities, but UHAS, or the University of Health and Allied Sciences, is the only university mandated by the state law to focus on training health professionals of all disciplines. And it is the research intensive. And I think that if we bring in digital health into the discourse of university tertiary level training, it will prepare the future health professionals to provide the care that we are talking about. So it would increase their employability, of course, when they travel. And because digital health is multidisciplinary, over the years, we talk about academics and those in the clinical area, the gap between them. But if we roll out digital health, it's going to create a space for the team to work together. And because of the research components of a university work, is going to help us to research in the area of digital health, telehealth, and publish to add to the existing knowledge to guide future generation. And of course, it will help in the generation of funds to help develop the university further. So just to say that the Act of Parliament established this university, and the health professionals that we train is across disciplines. And I want to emphasize this, it's across disciplines. So we have medicine, dentistry, public health, nursing, midwifery, physiotherapy, laboratory sciences, just name them. And so I think that if we are able to bring tertiary level training into the discourse of e-health, telehealth, telemedicine, digital health, name it, whichever name you want to use it, it is going to enhance teamwork. It is going to help us to bring research from the very foundation of all our activities. It is going to help us train people not only to provide care as an assessment and treatment, but also, like the first speaker said, in areas of artificial intelligence and all other areas, we can train people so we can keep the space alive, and we can develop human resources who are capable of providing health using technology. And of course, because this is technology, we can reach out to other countries, not only our small country, and we can also mentor others as we go on. So I want to end here, and because I'll be leaving, I don't know whether the moderator will allow 1 or 2 questions before I leave. But I want to also emphasize that we are working with Dr. Sohail and others to establish a health technology center of excellence in my university, which would include an area for robotics, AI, and others, and then telehealth on the wheels, as well as a training center. So we are still working on the proposal, and we are looking for funding. And I'm calling out to partners here, anybody who is willing to work with us. Our doors are open. And so thank you very much, Derek.
Thank you so much, Dr. Aziota, for a very interesting
the name is Aziato.
Aziato, thank you so much
Yes.
for the correction in the pronunciation.
Thank
you have raised important questions in your presentation, and issues highlighted progress in terms of what the university is doing. You have also remarked on capacity building, the future emerging technologies, AI, robotics. We'll pause for a brief interaction, and I have a question for you, Dr. Asiato. And I would encourage the audience also, if we could have one question before Dr. Asiato leaves. Dr. Asiato, just for your reflection, we're thankful for the work that is being done in Ghana, and at the same time for the inclusion of academia in the transformation of digitalization. If you could speak to us on the question of what changes in the mindset you see in health community in Africa in the context of use of digital health, especially post-COVID-19. Your reflections on that issue?
So, thank you very much for the question. I see myself as a typical African who believes that healthcare is not only Western, but also traditional. And now we at the digital space, are we going to bring this on board from day one, that the devices we are producing, the software we are producing, the approaches we're going to use, will it include traditional, complementary alternative medicine, or only Western? And now for us to reach out to our people and capture them whole, it is important for us in this space to think about how we can incorporate both sides, so we can reach out to the African who believes in traditional medicine and the one who also believes in Western medicine. That said, it's also how we can validate. So you want to talk to Lydia, you have not met me before. How do you know that the one talking to you now is Lydia? How do we get our people to understand the need to have integrity, be truthful when, okay, so I just want to put this across, that I know of people who use somebody else's health insurance card to go to hospital because the person cannot afford. And so my name Lydia becomes Joanna. Okay. Now in telehealth, you can't see me. You can only see me like you are seeing me now most of the time. So we need to find how we can validate to ensure that what we are doing, the targets and the process is true. Another reflection that I have is, how do we bring on board those who cannot read and write? It is true that within Africa, within one community, somebody cannot understand the other person's dialect, the local dialect, and somebody hasn't been to school. And even if the person has been to school, so I just mentioned that our neighbors are Togolese, they speak French. How much French can I speak as a vice chancellor? And so if I'm visiting Togo, how do I communicate? So I can continue speaking and speaking, but I know that we are limited for time. So my reflections has to do with Western traditional complementary alternative medicine. It has to be validation because of the peculiarities we find. People are not truthful. People do not present what happens, let me just leave it there. And then the issue that we need to find out how we can do multilingual services using telemedicine or digital health. Thank you.
Thank you so much, Dr. Asiato, for your intervention, cultural issues, also really thinking about digital inclusion and also equity. Thank you so much for the wonderful intervention that you provided, and we appreciate your time to share with us the knowledge. Thank you so much, dear participants. Would like to now proceed to the next speaker, who will be speaking for 10 minutes, and I once again encourage speakers to adhere to 10 minutes. And as a way of reminder, we do have some simultaneous interpretation. You should check at the bottom of the Zoom screen. You have a language option to choose to listen to French or English. Our next speaker would be Mr. Daniel Foloyan, who is a research fellow and technical assistant at Africa Center for Digital Health and Policy Research. He'll be speaking on the topic digital health policy in African countries. Daniel Foloyan is from Nigeria. Mr. Daniel Foloyan, you have the floor.
Okay. Yes, thank you, Mr. Derek. I'm with you.
All right.
Thank you, Mr. Derek. I'm with you. Yes. And I want to appreciate COMSATS for this privilege. It's a very great one. And I'm also grateful for, of course, what the first speaker did. It was a very good one. I want to go ahead to share my screen now so that you can follow my presentation. Okay?
Over to you.
Can you see it now?
Yes, we can. Over to you.
All right, very great. So basically, I know that in 2015, September 2015 to be precise, there was an adoption of the 2030 Agenda for Sustainable Development with 17 SDG goals. And basically what our focus is and what it will be for today is the Sustainable Development Goal 3, which focuses on good health and well-being. Okay, so I'll quickly run through what digital health is. I would also look at what policies are, or what is the meaning of policy. Then I'll give an overview of what digital health policies in Africa is at the moment. Of course, I would also try to give what it was before the COVID era, the pre-COVID era, and again, what it has been now. I won't say we are in the post-COVID era because COVID is still with us, just like we have malaria. It's just that in most of our countries globally, the effect has subsided. So basically, of course, digital health is just an inclusion of technology into health. And just like Professor Aziato said, digitalization of the health sector is actually the way to go. And when we talk about digital health solutions or digital solutions in health, we're talking about telemedicine, telehealth, mobile health, wearable devices, electronic health records, and all that. As a matter of fact, Africa at the moment, in fact, just like Derek said the other time, Asia and Africa has the population. And of course, very significantly, we need to focus more on the digitalization of the health sector. And what do we mean by policy? Policy simply means rules and regulations set forth by lawmakers. Of course, it could be at the local level, it could be at the state level, it could be at national level. And what these policies do is that they impact fundamental health issues, okay? It could impact privacy, it could impact medical jurisdiction, it could impact costs, it could impact delivery methods, it could impact liability or reimbursement of e-health services such as telehealth and what have you. So basically, I want everybody to follow me as I speak on this very particular part. So as I give an overview of digital health policies in Africa. Of course, Africa serves as the test bed for most digital health intervention. That's the truth. There are several interventions coming out. I have a friend at the moment who is working on improving health outcomes in Africa, particularly on Down syndrome. Few months ago, there was a conference I had with a Gambian friend, and what he talked about happening in Gambia was an introduction of smart vaccination. Okay, so there are several interventions coming up in Africa to manage diseases, to manage several degenerative diseases, cancer, and what have you. However, the unfortunate thing is that over 60% of the countries in Africa do not have policies. And of course, this has opened us or is exposing the countries to violations of privacy and of course, ethical practices. So this chart shows the status of digital health policies in Africa in the pre-COVID era, particularly 2018 and below. Out of the 54 countries in Africa, I mean before COVID now, that was in 2018, only 22 of this country had digital health related documents. Just 22 out of 54. Of course, that was not up to 50%. And out of this 22% that has digital health related documents, 82% of such documents were just strategies, while about 36% of such documents were policy. You would see that that was very low, in fact, poor. However, just like the secretary said the other time while he was giving his speech, I discovered during my findings that COVID-19 led to a surge when it comes to digitalization of the health sector in Africa. In Nigeria, particularly, I remember in 2019, a school, a polytechnic, a tertiary institution had to develop a ventilator. Malawi, Kenya, Uganda, South Africa did some interventions digitally. And of course, we saw that there was a surge in digital health, digitalization of the health sector. And at the moment, or let me say the post-COVID era, like I said the other time, COVID is still with us. COVID is still with us, actually. It's just that it has subsided in some of our countries. We'll see that there's an increase in the number of countries that now have digital health related documents. Between 2018 and now, it has shot up from 22 to 44. And that's about 82% of the countries in Africa having digital health related documents. We can see in the charts, we'll see that strategy or plan, that's about 82%. Then just about 18% of the African countries do not have strategy or plans. However, less than 36% of these countries, that's about the 44 countries, less than 36% of these countries have policies in place. And can I say this? In 2017, there was a document that was released by World Health Organization, Global Health Diffusion of e-health. And that document stated that about 27% of the countries worldwide have policies in place for digital health. However, in Africa, as at the moment, as I speak with you, less than 36% of the 44 countries with digital health related documents have policies in place. And in fact, as a matter of fact, some of these policies have failed to address realistic health challenges due to poor designs and implementation. Okay, I'll give you to a few countries like Ghana, South Africa, Kenya. I know Uganda is trying to, and maybe Nigeria. As a matter of fact, South Africa is one of those countries that have policies. Then there's public funding. Of course, they have some legal frameworks too. And in Ghana, the Ghana health policy is running to an appreciable extent, running fine. And mobile health is also established. And of course, one of the things that is happening in Ghana at the moment is that there's use of learning in health sciences, just like Professor Lydia Aziato said the other time. And of course, we have some of these things running in Kenya, Uganda too, and Nigeria is trying. I'm not saying that because I'm from Nigeria, but of course, there's a level of improvement from what it was in 2018 at the moment, as I speak with you. As I round off, what can we do when it comes to digital health policies in Africa? How do we predict digital health policy development process in Africa? With us, I have a chart. The first thing basically we need to do is to conduct needs assessments. Basically, when we conduct need assessment, of course, we know that we are going to do initiation, data collection and analysis. Then, of course, we come with the final product. Needs assessment help us to determine the needs or gaps between the current status and the desired outcomes. So when we conduct the needs assessment, we'll see whether we need policy. And once we are sure we need these policies, of course, it can guide us to create plans and design. We can create draft policy. Then, of course, having checked, we'll validate the draft policy. And once we have done that, the next thing is to seek approval. And of course, the next thing is implementation. And of course, once these designs once these policies rather are well implemented, they're expected to be followed and funded. In fact, that is one of the challenges we have. There's no public funding, okay? And of course, year in, year out, these things should be reviewed and well evaluated. It is important. And one thing I also had is that, of course, beyond the implementation of the policies, yes, the policies should be launched and published so that stakeholders should be aware. So as I round off, let me quickly give my recommendation. Of course, number one is that well-intentioned policy should be formulated on digital health in African countries, because as it stands, African countries have little policies when it comes to digital health. Yes, we have interventions, but the policies are few. And in fact, these few policies are not really working in most of our African countries. Then these policies should be properly implemented. And having implemented them, they must be revised or reviewed intermittently, okay? And of course, having revised them, they should be published so that stakeholders can be aware. And on these notes, I want to draw the curtain of my presentation. Thank you, everyone, for listening.
Thank you so much. Yeah, thank you so much, Mr. Daniel, for that important presentation and intervention on policies for digital health, which are very foundational. The African region, WHO Office for Africa, will be releasing an updated survey to just augment the discussion that has been provided. There is a question in the chat, which we'll deal with at the end, mindful of time and mindful for other speakers to take the floor. We'll leave the question towards the end. And so Daniel, I'll give you a chance to respond to the question in the chat after the speakers have completed. Right. Let's move along, colleagues. We are short on time. And so reminding speakers that will be taking the floor to be mindful of time, and I'll provide a 1-minute warning once the time allocated is coming to an end, to just be succinct so that we're able to get to the end. Our next speaker will now be speaking on the topic, the evolution and future of digital health in Nigeria. This will be delivered by Ms. Onyindamola Songunro, who is the Chief Analyst, E-Government, Department of Federal Ministry of Communications and Digital Technology in Nigeria. Over to you, Ms. Songunro. You have 10 minutes. If you could deliver the presentation in 10 minutes or less, that would be appreciated so that we're able to catch up with time. The virtual floor is yours.
Thank you very much. Good morning. Please, can you put up my slides? National Health Information and Communication Technology, that's Health ICT Strategic Framework, was completed in 2015 through a multi-sectoral stakeholder approach led by the Federal Ministry of Health in collaboration with the ministry where I work, which is the Federal Ministry of Communications and Digital Economy. And we actually developed this strategic framework using the eHealth, WHO ITU eHealth Toolkit. The framework incorporates the effort and the input of over 150 public and private sector technology, health and technology sector stakeholders, which reflects that it covered feedback and recommendations from a wide spectrum. If we move to the next slide, please, we'll be talking about the vision of eHealth in Nigeria. Now, the national eHealth vision for Nigeria is that by 2020, Health ICT will help enable and deliver universal health coverage. I've put this in red because there's been a review of that document and it's being presented right now with the National Council on Health, which is going on right now in Abuja, Nigeria. The review of the digital health strategy for Nigeria is going to be discussed. The policy for that is also going to be discussed. And I've mentioned that at the bottom of this slide. If we move to the next slide, please. Okay, yes, thank you. Now, the document that we have currently, the one that is approved, is a three-part document, and it talks about the health ICT, that's eHealth, context and vision, the action plan, that's how we're going to go about implementing it, and the health ICT monitoring and evaluation plan. We took our guide. It was a 5-year vision of which we have done the monitoring and evaluation last year, and we submitted our report. We're just waiting for the National Council on Health to adopt, and then we can circulate to the general public. Please move on to the next slide. The National Health ICT Strategic Framework, also eHealth, was approved for operationalization at the 58th National Council on Health meeting in March 2016, and it's available on our website. You can check it, and it's been reviewed in 2021 to 2022. The strategy provides stepwise guidance for the achievement of universal health coverage using the 7 components of the health ICT enabling environment as recommended by the WHO ITU National eHealth Strategy Toolkit. If you move to the next slide, please. The following achievements have been made. The creation of a high-level governance structure with a steering committee consisting of the ministers of the Federal Ministry of Health and the Federal Ministry of Communication and Digital Economy as chair and co-chair, a setup of technical committees, technical working groups, and the eHealth Project Management Office. The eHealth strategy was cascaded down to the states. States were invited so that they could operationalize the eHealth strategy at the state level and even penetrate to the local levels, as to the primary healthcare centers. Provision for dedicated funding, there was a provision for some dedicated funding for eHealth in Nigeria. Next slide, please. Also, one of the achievements is the successful launch of a self-reported inventory on eHealth tools in the country. We're trying to get a wide-scale understanding of what is out there, because not all the implementations are being done by government, some are being done by private sector. They might not inform government. So we have this toolkit to help us to harness that information, that we can use that to build on what does Nigeria need next. And then, of course, the development of a draft national eHealth policy to give backing to that eHealth framework. And also the adoption of ISO's international standards, ISO TC 215 on health informatics, which is being spearheaded by a national mirror committee. Next slide, please. Now, we have 5 technical working groups that are in charge of technical expertise for eHealth in Nigeria. We have the Health Information Exchange and Standards. We have Data Systems Technology, Human Resources for Health, Infrastructure, Legislation, Policy, and Compliance. If we move straight to talk about what are the challenges to the implementation of that, and we would say that is a post-COVID implementation. Next slide, please. The major challenges to the full implementation of uptake has been the lack of dedicated funding mechanism for coordinated eHealth activities and initiatives, and getting stakeholders from all levels to adopt it and not just see it as just a federal thing or a development partner thing, but as a role for the whole of Nigeria. With that, I'd like to go to going forward, the futuristic view of the digital health in Nigeria. The following methodologies have been identified by the team in Nigeria as being imperative for digital penetration at health facility levels in Nigeria. First, we need to review and ratify the digital health strategy and policies. We have to disseminate this at all levels and make it understandable to all the stakeholders in that ecosystem. We have to have a more dedicated funding mechanism to help the implementation be better. Fast track deployment of broadband infrastructure across the nation, actually, with focus on underserved and unserved areas. And of course, we have to have robust monitoring and evaluation framework so that we can monitor what is working, and when we need to change course, we can change course as fast as possible. If we move to the next slide, please. Okay, these are the expected deliverables. It is expected that there will be an alignment between the national health ICT policy with the e-health policy, rather, with relevant national health policies and plans, so that there's no disparity and we have a one focus. We have to leverage on the Nigerian e-government master plan as a foundational tool to enhance digital health initiatives and implementation, and also to ensure that we have something that we call interoperability, to ensure that all the systems that are built, all the applications and the services can speak to each other, and it will make the national health information system work better. There has to be stakeholder engagement to review the ongoing implementation of e-health in Nigeria. Stakeholders need to align their resources and work together in their programs and activities with the goal of e-health strategy to consolidate efforts towards the achievement of universal health coverage. Next slide, please. We also have to have financial support from the federal government, state governments, and donor agencies that will be streamlined towards digital health implementation. Across the 5 technical working groups I mentioned earlier, we need to share experiences between stakeholders so that there can be a knowledge database that would help to learn from what is working in one region or one country, so that we don't have to start the wheel from the beginning. We also need to have technical support for the achievement of the set objectives of the digital health in Nigeria. And on that, we've been talking with WHO a lot and UNICEF, and presentation of the report and recommendations to the technical committee, and of course, to the steering committee for ratification and adoption. With that, I have come to the end of my presentation. I will wait till the end for the questions.
All right, thank you very much for that very timely presentation that captured critical items, learning from Nigeria, the issue around the resolutions on digital health in the African region, in the globe, then approach towards national strategies. The example from Nigeria was quite useful in the pillars, and also relationship with the ISO, but much more importantly, the issues around the enabling environment, the whole of government approaches are quite critical. Thank you so much for that intervention, Dr. Sungunro. We do have to get to the next speakers, and we're running out of time. And again, dear speakers, I'll try to encourage your expedition in presenting. Checking if we do have Dr. Vuma Magakwa on the floor to provide the intervention. If not, we'll go straight to the next speaker, who is Dr. Joanna Eva Dodu, who will be speaking on the topic digital health in Ghana. Dr. Dodu is basically working with the University of Cape Coast in Ghana. The role is Registration and Examination Officer, Business Programs, College of Distance Education. I should be giving the intervention. If you could provide the intervention in 5 minutes or less, that would be appreciated so that we're able to get to the end. Dr. Eva Dodu, the virtual floor is yours.
Thank you. Thank you, Mr. Derek Munene, and thank you to COMSAT for organizing this important webinar. May I know if my slides could be shared?
Thank you very much. Asking the technical team to help with the sharing of slides once again.
All right. So as I indicated earlier, this conversation is very important. And my presentation will be based on an outcome of research that used the systematic review method. And so these outcomes is meant to help us understand the state of knowledge with regard to digital health applications and use in Ghana. So my presentation outline will look at digital health in Ghana, where we are now, and I'll also give an overview of the progress of digital health use in Ghana, the acceptance of digital health. I'll also mention some of the challenges that have been experienced in the course of digital health use. And then I'll move on to the critical issue to discuss where we are going with digital health, and we'll conclude. So where we are now in Ghana, I can safely say that Ghana currently has adopted, Ghana is going digital. Ghana has gone digital, and we have gone digital because we know that it will help with improving the efficiency of the larger macroeconomy. And this acceptance is buttressed with the point that currently we have seen an increase in the use of digital health systems, up to 77%. And my earlier speakers talked about digital health. They took time to explain what digital health means, so I won't go there since we have to manage time. So I will jump in quickly to the progress in digital health. In digital health application, historically, started somewhere around the 1980s, which projects like the HealthNet telemedicine, we had the CNPDA national project, medical line consultation, which were sent to the remote areas to help with accessibility to healthcare. And from the 2009 towards 2014, 2019, we saw expansion in telemedicine implementation in the country. And so there is teleconsulting, teleradiology, and so we were expanding the systems to help in the telemedicine implementation and use. So we can say that generally there is an acceptance. And this was also backed by the National E-Health Strategy, which was launched in somewhere 2010. So through this e-health strategy, which was launched, a number of health facilities were connected, which helped with automation of pharmaceutical services, patient registration, and record keeping. So when you go to hospitals, many hospitals, paper-based record keeping, it's almost minimal because now we use the electronic form. So the general acceptance is important for the digital health uptake. However, we have some challenges, and these challenges were themed into 5 main categories. So we have organizational challenges. And with organizational challenges, it was mainly due to initial buy-in from clinicians, especially if there is minimal engagement with the primary users, there's bound to be some form of resistance. And so these were some of the challenges that were encountered. And then technological challenges was another problem with the implementation when it comes to the network connectivity, the quality of bandwidth. And so from the research outcome, we found that when the network is very low, the connection is very low, it delays in transmission of information from the primary healthcare giver to the other consultants at the other end in the telemedicine consultation. There is also the legal and regulatory challenge. People were concerned about the safety of their medical data. And another challenge has to do with the financial challenge, because it was a bit costly. It was costly setting up telemedicine systems, maintenance, and then cultural. I think Professor Aziato mentioned about the cultural aspect when it comes to, so this was also another challenge. Many people have their own reservations. They believe that receiving medical attention, they should be able to see the person face to face, have an interaction. It has some psychological effect. And so when that is not there, it also has some resistance. So these are where we are now and where we are going. So I'll present my discussion on where we are going based on COVID. When COVID came, it taught us resilience, and COVID also helped to legitimize the use of digital health systems in healthcare provision. And so in Ghana, we deployed the drone technology for delivery of medical supplies, which was seen as fast and reliable in helping with emergency healthcare. And we also used the digital technologies. One of it was the COVID-19 tracker, which helped to self-assess yourself and report your COVID-19 symptoms. These, among other technological innovations, came up to help in strategies that will curb the COVID-19 pandemic, its effect. After the COVID season, well, one of the panelists said we shouldn't say COVID is post-COVID because it's still here. Yes, it's still here. But we know that we have been able to bring it down to a minimal level. So looking at the post-COVID-19 era, research findings suggest that 93% of primary health caregivers still use the digital health applications in their daily work, which is also a good signal of acceptance and continued usage of the systems. There is an increased e-systems for public campaigns, education, to help people understand the health implications and also know the measures to use to prevent. So, and even the Ghana Health Service seeks to focus on e-health for health promotion. These are some quotes. One person said, well, if I consider going to the hospital, queue for long before I see a doctor, when I can receive healthcare remotely, for the sake of convenience, I will opt for digital health. Another also said, I think it's a very good thing. It reduces waiting time for receiving a medication and also quickens healing process. You will receive promptings. However, as a Ghanaian, I think it prevents me from that face-to-face contact with a doctor. You know, seeing a doctor is also part of the healing process. So it should not totally take the place of face-to-face contact with a doctor. Another also has this to say, that I believe these systems are very good, but his concern has to do with data protection. He says these systems can be hacked. And so if these systems are hacked, it means medical data are unsafe to the public. Fast forward, we have seen a number of digital health innovations in the country. So a number of apps have come up, and these are indigenous startups from the private end, signifying buy-in and then participation from the private sector. And these are very good. And I believe when these startups are encouraged, it will help with digital health systems. So we have the COVID-19 tracker is still there. We have Hewale, social health, digital health access, M-Pharma, that is also into pharmaceutical delivery of medical supplies. And in conclusion, I will say that COVID-19 indeed has increased the legitimacy of the use of digital health application towards healthcare provision in Ghana. However, there is the need for us to leverage on the full range of digital health systems so that we can harness on its effectiveness to help in the delivery of healthcare, help in safety, health, and well-being of citizens. Based on this, I think that the identified challenges that has been mentioned earlier on, and then reservations that have been expressed earlier, we should take measures to address them so that we can increase awareness, acceptability, and digital inclusion. Lastly, a national strategy and policy that seeks to promote service quality factors of digital health application will be very important in our conversation. And so on this note, I will end my presentation and I say, Medase. Thank you for listening.
Medase, thank you so much for the presentation. Dr. Dudu, you've highlighted the number of points around the work in Ghana, telehealth, and also the COVID response. So quite thankful for your intervention. There is a question in the chat. If you could look at the question in the chat that was asking for the specific technologies, we'll see if we have a moment to interact at the end for you to address the question. Let's proceed to now to listen to Dr. Asuniel Chingati. If we could already deploy the presentation as I introduced him. He's the Director of Medical City Online, CTO, the Health Bank Global, orthopedic surgeon, Harley Street, London. He'll be speaking on the topic, virtual disease management via clinical telemedicine in Africa, design of services. Once again, if we could welcome Dr. Chingati to the virtual floor, and please, if you could help us save on time by focusing on the key aspects of the presentation. Over to you.
Thank you very much, Mr. Munine, and I appreciate Dr. Azima Shahid's effort and also the ex-ambassador Nafis Zakria, who chaired this meeting, the executive director. It's a wonderful effort, and I appreciate that everybody has taken time to come. So I get on with my topic, which is why clinical telemedicine, not video consultations. And that is for Africa, because video consultations, in my view, are very kind of a very primitive part of management of disease remotely. When we have the option of going a proper virtual management of disease, why not use the opportunity, and why underplay? So if I can just take you forward, this is the normal video consultation, doctor-patient meeting on a screen, and the doctor kind of trying to help with the patient as if the patient is in the clinic. And this is clinical telemedicine, where a disease is being managed. This is a design of one of my software where doctor is guiding the probe to be put on the patient's infrasternal region to look at the heart so that a clinical decision can be made. So clinical telemedicine for Africa, in my view, will help to manage the disease and also to convert people who feel that they just had a Skype or Zoom with the doctor, but the doctor, they still want to see the doctor. That confidence of patient, where the workflow of the doctor requires to be still clinical, is my way of actually converting public and doctors both to have confidence in the telemedicine. So basically it takes a software, as I can just point out, it takes a properly designed software, which can be incorporated with a clinical decision support system. And to add the functionality of multi-channel video input, which means that multiple inputs can come in, and then you have to have a layer of the hardware, like ECG machine, stethoscope, glucometer, all of that can be embedded seamlessly into the port. That's an example of how I embedded one of the monitors I've got with me, where I'm putting my finger and the person on the other side can see what is a live single lead ECG, my pulse oximeter. And that is where you make clinical decisions rather than just meeting a patient. You make clinical decisions based on evidence. So video conferencing is just this, where you meet a doctor and patient like we're meeting now, but the rest of that is what we do in clinics in some part or other. That is the workflow of a doctor. So I have constructed my own workflow, being an orthopedic surgeon, into a virtual workflow. And I believe patients have more satisfaction, and even doctor, the caregiver, feels comfortable with that. For example, any non-life-threatening symptom, there is a workflow. The software will tell whether this patient should go to online doctor or whether should go to hospital. So that's the front end of the software, which guides the patient for non-urgent symptoms to make a decision, shall I go to hospital or shall I see an online doctor? That is the question everybody will ask, that should I go to a hospital or shall I just speak to a doctor over the telephone? So that is the software, like a nurse sitting on the phone and taking the patient through that questionnaire. And at the end of that, a decision is made, let's go to hospital or let's see a doctor online. So then comes the point of booking appointment. The patient will have option to book an appointment. What will normal people do when they have symptoms? They will pick up the phone or they will look at their website and they will book. And that is what they do in this system. Patients will book an appointment seeing all the doctor's credentials or the specialty or the positioning. Now, distance does not matter here. A patient sitting in far of Ghana can see somebody in south of Ghana, anybody in Africa across the continent from north to south. A doctor can see a patient regardless of the geography of the distance. Now, there is a nurse triage. When we go to a hospital, normally a nurse will see us. That is what I've incorporated in the design, where a nurse, a software-based nurse, will actually triage the patient. So that basically takes away, that does two things. It captures the data in a very systematic way so that it can be used, and it takes the doctor's time away. So the doctor doesn't have to spend time in repetitive questions, what is your symptom, what is the past history, any operations in the past, any allergies. That is being done before the doctor sees the patient online. Then the patient is put in the waiting room. That is what normally happens in the real life. Patient is waiting. And that is what happens in a virtual medical practice. In this software, as I said, I just recreated my whole workflow into virtual. This is just one screen where patients are waiting and doctor will now call them in. And the doctor opens the door physically, come in, I'm ready now. That is what they do virtually. They will click the bell and the patient's phone will ring. Patient will accept the call and the patient meets the doctor, just like that. So this is the doctor in the corner, this is the patient in the middle, and the doctor has got a work tool, a workflow, these are all the tools which a doctor will do in the clinic. All the things I've tagged in the small folders, what a doctor will need to do. You don't have to do all of them, but whatever you need, you have them at your fingertips. For example, you can invite a relative. You can send the link to a relative or an interpreter or a colleague to come and join us. Patient can give a consent. You can read the consent. Patient can fill a basic form. This form is usually offered to the patient when they book an appointment. If they haven't done that, doctor can help fill that form. Then the doctor can examine symptoms and the doctor can open a form which is based on that symptom so that you have a data capture system, so that you can train the junior doctors how to analyze the symptom. So it's a training symptom as well, not just an examination system. And then the wound assessment form is another example. Then the doctor reviews the existing medical records. And that's what we do in the clinics. Doctor will say, look, let me look at your file. But the problem is when the doctor is looking at the file, the patient is looking at doctor's face. In this example, the doctor and patient are looking at the same screen. Like the patient has got a similar screen at home and the doctor and patient can talk while the patient looks at the screen and asks questions. That what is that finding? So the engagement level will increase. And the doctor can open the EMR on his screen and share with the patient. For example, this is a setup of NHS I've deployed. One of the GP surgeries here, where a doctor can open the NHS record in front of the patient. And then the patient can send the pictures of the investigations they have captured using their own phone. So other thing we do in the clinics is recording the vital signs. Now, this is where the dependency is on the patient side. But there are so many devices available nowadays. For example, you can discuss the investigations with the patient uploaded all the documents, the lab reports. Patient can upload x-rays. Patient can upload screenshots of the devices on the mobile phone, and then the medical examination. Now, I must mention here that in our medical training, as you know, any of those who are doctors in the audience, they would know that the history taking is the critical part of a diagnosis. Many conditions are diagnosed on the basis of history, and they are only confirmed by medical examination. And nowadays, investigations. So there is a gap between a physical examination and a visual examination. But if the doctor adapts to the technique, for example, examining a shoulder, you don't have to touch the patient. You can ask the patient to put the hand on the back of the head. That is external rotation. Hand at the back of the back, that's internal rotation. Where is the sensation? If the normal is 10 out of 10, what is the abnormal sensation out of 10? So there are so many visual adaptations to the physical examination you can do once you learn this technology. And I must make a comment here that nowadays the barrier to the growth of telemedicine is not the patient, not the regulators, not the donations, it's the doctor. Because the doctor does not learn the technology with that much confidence, and the patients feel jittery. The doctor is learning himself something. And that is why the patients are, I mean, just imagine that if a patient and doctor meet in person and the doctor is not showing confidence in examining the patient will not be happy. Same way virtual. So virtual is no different than physical. If you have learned virtual well, you can satisfy the patient. I've published my own papers of my own data of 1,000 consultations virtually, comparing with 720 physically in COVID of my own practice. And my virtual patients were happier because they had so much benefit, plus they were satisfied with the examination. That's one way. Like in this case, the doctor is telling the patient where to put the camera. That's a multi-channel telemedicine. And then patient can record the vital signs at home using devices, simple devices, don't have to be smart devices, and then enter the readings. So this means that when the doctor sees the patient tomorrow, the patient has done the recordings for today, and they can serialize for the whole week. And then doctor can view their progress. These are some screens like that. Now, preparing the clinical notes. In clinics, we write notes. Same way, we can type, we can voice dictate, or we can dictate audio and send the MP3 to the secretary to type it back. All of this is available in such an interface. We can refer the patient, and that letter is already prepared by the artificial intelligence in the system, which means that whatever the doctor has done so far in the clinical consultation has been recorded as a visual analog, and that gets referred to the next consultant. So this is again done automatically. We do this, we do the prescription, just like we write a prescription here, and we look at the prescription and automatically dispatch to the pharmacy we reckon that should go to. And that is again possible in this mechanism. This is far quicker than a physical examination and asking the patient to take the medicine and go to the pharmacy. That pharmacy in this case will ring the patient, do you want the medicines delivered or are you coming? Same way, that is a summary of the consultation that can stay with the patient. In NHS, I am giving this PDF copy to the NHS GP surgeries so that we outsource the consultation, which means the PDF summary goes back to the NHS records. And that is where we're trying to lower the NHS workload and waiting times. That's again our calendar. I would say, Mr. Munine, to stop me if I'm going over the time. Now, patient education is very important. I believe that's part of the consultation. The doctor can explain something better with pictures, and patient can ask questions, and these pictures can be emailed as well to the patient like this. And you can show videos of using inhalers, using glucometers as well. Now, the clinical telemedicine for Africa, the scope, the impact, the deployment, and case scenarios. Chronic conditions, including cancer, they can be done to telemedicine, clinical telemedicine. And acute conditions which are not life-threatening, not bleeding, not fractures, not breathing troubles, not chest pains. Those are which are acute, like simple ankle sprains, like a small cut on the skin without bleeding. They can be dealt by telemedicine. And all these conditions, chronic conditions of cardiac, pulmonary, pediatric, cancer, orthopedics, gynecology, ENT can be managed. So let me take you through the ecosystem. This is what my vision is for Africa. We need to create a virtual healthcare ecosystem for Africa, which means that it's based on a clinical telemedicine system, which has symptom-based forms, which has virtual supervision, which has clinical guidelines, and a clinical decision support system. That summarizes what my presentation is about. I'll just show 1 or 2 slides to summarize this. That system should have auto dispatch to pharmacy, interspecialty referrals, auto dispatch to radiology lab, to pathology lab. And this is what I believe is the vision, is the benefit of clinical telemedicine. All this can be done by means of no contact. That controls the infectious diseases, that saves patient time. The cost to serve ratio of setting up a system of e-health is far better than a physical system. I'll give you an example here, a quick one. Take an example of a bus, a telemedicine bus. Now that can travel in far areas of Africa connected to the teaching hospital. And that has 22 specialties technology laden. There's only a GP sitting here, not the specialist. And then look at the other option, like this bus. That bus can travel from place to place and still connected to the teaching hospital. All these specialties are covered. And then you have, this is a room in Lahore in Pakistan, where I'm examining a patient's shoulder through a clinical telemedicine system. I don't have to be there. That place is 6,000 miles from my place. By the way, talking of Pakistan, I will show you a little books page as well. Mr. Nafees Zakri is sitting here. He wrote the preface of my telemedicine book when he was ambassador in UK. And he was very kind to encourage me to write a book and share my story of 500,000 patients of Pakistan COVID helpline, which we developed for the country. So
Right.
This is by the way, another screen, and I will stop here just to, I don't want to hog anybody's time. I'm conscious, but I have so much to say, and I just want to show this book, which has Mr. Nafees Zakria's preface, and I thought it's an opportunity for me to say thank you to him. I didn't say it properly. That is Mr. Nafees Zakria. He wrote the preface of my book. It's in Amazon and many medical college libraries. Thank you.
All right. Yeah, thank you so much for that intervention, Dr. Sanhel Gutai. We do have a need to continue to the next presenter, but I would like to give chance to our ambassador, Dr. Muhammad Nafees Zakaria, who has a question, as he has a prior commitment to present a question for this particular intervention as we prepare to go to the next speaker. And as we have already gone over time, respected participants would indulge your understanding for us to listen to 2 more speakers and then we close. Ambassador, the floor is yours.
Thank you very much, Mr. Derek. Thanks, Dr. Sohail, for your kind words. I have always found you very excited about your profession and how you can actually benefit the humanity with your expertise and with your your profession. I remember many years back when we were together in UK, you came up with this idea and then we worked on it, telemedicine and telehealth. So telehealth, telemedicine, or teleclinic, whatever you might call it, it's a very sought after field now, and innovations are leading the way. I have heard the other speakers, they have provided valuable inputs as well as shared their ideas and as to how they things are being managed in their respective countries or regions. That has given me an idea as to what sort of intervention we can make from the platform of COMSATS in the field of telemedicine or telehealth or teleclinic, so that member countries and those who are abetting in terms of boundaries, the member countries of COMSATS should be able to benefit from the expertise that we have achieved. About Dr. Sohail's presentation, it seems that you are looking at a scenario where everything would be virtual. I think for some time to come, it has to be a combination, and it would be a hybrid system. As far as the developing countries are concerned, as well as because you will encounter so many impediments on your way to becoming 100% virtual. So I can foresee that, not that you can't foresee it. I'm sure that you must be aware of it. But I know since you are sitting in an advanced country, your experience, your exposure, and your dealing with the people gives you a different impression from the people who are in part of the who form the population of developing countries, where the literacy rate, the infrastructure, the remote areas, and the outreach and are some of the things that would be an impediment. And we will overcome that with the passage of time, inshallah. Dr. Sohail, I have just one question, that you have given such elaboration in which the doctor to patient contact, virtual contact. It seems that I'm just inquisitive, that is it the same time that doctor would be spending with the patient virtually, or as I see it, it would be more time, which the doctor usually spend with the patient when they come to them physically. I see that maybe this will require more time between patient and the doctor. I just wanted to be clear about that, as far as your concept is concerned.
This is a very, very relevant question, and this came up a few years as well in many conferences, that doctor has to spend a lot of buttons and here and there. But if you just look at the process, when the patient books an appointment, that's the first point. And as you book an appointment, a quick small form comes up. Any allergies, any medications, any long-term diseases. So these three questions doctor was going to ask, which the patient has provided at the beginning. Now, while the patient comes in the clinic, in the waiting area, there are some other questions which will be automatically cropped up depending on the patient. Female patient, male patient, that is the artificial intelligence system, which will pick up the right questions for that patient waiting. So when the patient comes in this clinic, the online clinic, the next when the doctor calls him, so many questions have already been answered. And the doctor only sees the answers and starts from the point of story where it was left by the predecessor, the automatic form, the electronic nurse, and then the doctor. So, and then also patient says, well, I checked my blood pressure last week, it was this much, and I've added to the system, or just tells a verbal. So many things have already been done. And then as I mentioned before, the barrier to telemedicine is not patient anymore. The COVID has converted the patient. The patient knows this is the way. It's the doctor now. If the doctor has the confidence and the understanding of the interface the doctor is using, and he believes that I can treat the patient this way, the patient will be converted. They're getting so much benefit. Yesterday I saw a patient in my clinic, online clinic. She was smoking in front of me in the clinic. Never have seen a patient smoking in my clinic. And she said, I feel so comfortable, doctor, I could smoke now. And there was last week, before that, there was a patient sitting with a cat in the lap, and she was making the cat, and she says, I'm very comfortable here. You come to my home today. I could pick up my post, I could pick up a bottle of milk. So all these things are giving patients the confidence, the benefit. The doctor is the barrier. If the doctor gets this sorted, this is the future. Thank you.
Thank you.
Thank you so much, Ambassador. Thank you so much, Dr. Sahel, for the interaction you've given us. We'll proceed, respected participants, to two more last presentations, and then we'll wrap it up. Apologies once again for overrunning the session. Please join me to welcome Ms. Joanne Stella Nakimuli, coming all the way to present for us from Uganda. So leaving West Africa, leaving the UK, now going towards the central part of Africa. She is a researcher at the African Center for Digital Health and Policy Research. She'll be speaking on the topic of digital health scenario in Uganda. Over to you, Ms. Joanne.
Thank you so much, Doctor. Could the technical person share my PowerPoint presentation, please, if you can? I'll be taking you through the status of Uganda's digital health system. And I'll be speaking about Uganda in particular. I'm coming from the African Center for Digital Health Policy Research. And just to let you know that Uganda is the Pearl of Africa. In case you've not known about that, we have a population of 44 million people. 80% of them are below the age of 35 years and 0.5% are above the age of 8 years. Uganda has a lot of tourist attractions, just in case you didn't know about that, and you're very welcome to see the Pearl of Africa. Thank you, Doctor, for sharing my screen. It is still sharing. Yes, I've been just explaining that. If you go to the next slide, please. Uganda's health system, the Ministry of Health has a structure where all agencies work together nationally and internationally to achieve the National Development Plan of 2021 to 2025. And we have a structure starting from the health centers, health center 2, 3, 4, the general hospital and the general referral hospitals, all the way to the national referral hospitals, which are all governed by the Ministry of Health headquarters, centered in Kampala, the capital city of Uganda. I'll also talk about the status of Uganda's digital health system. Just to let you know that several of the e-tools have been developed with current technology to help in the health industry, which include patient-doctor video conferencing, of which several of the other participants have talked about. We have sensors for remote monitoring of physical activities. Doctor has spoken about that. We have drone technology for transporting biological products like blood products, vaccines, and life-saving medications to hard-to-reach locations. And not everyone is able to get such services, but with the drone technology, they're able to receive all that to where they are. We also have electronic dashboards for tracking disease outbreaks. For example, like tuberculosis, we have different technologies that have come up and they are able to detect tuberculosis with children in specific. We also have cloud-based databases for storing and retrieval of patients' clinical records, referrals, and electronic directories for locating health facilities in Uganda. We have mobile applications of recent during the pandemic. The mHealth, Rocket Health have all been in production and they are currently in use. If you go to the next slide, please. That is the digital health coverage in Uganda. The plan for Uganda's universal digital health coverage has driven by various innovations, approaches to expanding health services to the general population in Uganda and Africa at large. Uganda has seen a significant adoption of these services, especially in the last 2 decades. Beyond utilization in communication, finances, and transportation, public health and healthcare services have seen greater applications of these tools, from disease outbreaks, infectious disease, contact tracing, telemedicine, electric medical records, as well as applications for medication prescriptions, just like the doctor has just spoken about. These tools have contributed to increased access to health services, improved clinical decision-making for clinicians, and increased patient engagement and independence in the Ugandan health system. People feel comfortable, they feel at ease, and they feel that everything is just going the way how they want. The next slide, please. I'll talk about the COVID-19 consequences in the health system. The pandemic worsened existing health access in the population, especially from low and middle income citizens, revealing a gap in access to care and shorter outcomes. There were limited movements facilitated, high usage of digital tools like phones. There was a record from the Uganda Communications Commission where they said that there was a high increase of people using phones and internet and social media to access doctors. That was through the increment of internet usage. There are also mobile health information dissemination, telecounseling, just like how the doctor has just been talking about, mobile medicine delivery through the drone technologies, through people, different hospitals introduced a system where Medicine would be put on a border transportation in a good package to the patient. That was all after the telemedicine conferencing and everything done by the doctor and the patient. There was also a rise in use of internet services for health research. Doctors had to use a lot of internet to get to know what is all going on, since COVID-19 was new to us, like you Ugandans. There was also development of online health call centers, which was not there before, and we saw that coming up. If you go to the next slide, please. I'll talk about the barriers to digital health system in Uganda. The major barrier is a lack of healthy digital infrastructures. In particular, that is affordable data access and devices. We also have lack of common data standards, which has prevented information sharing for proper decision-making purposes. Apparently, digital divide among the public has also been another challenge. There's a gap between the old age, the low socioeconomic status, literacy levels, which are all hindering the use of the digital health in the healthcare system. We also have limited coverage and poor network connectivity, which is a very big problem. But we have seen companies like Airtel, MTN coming up and helping up to speed up that with low costs for people to access, of course, healthcare. We also have fear by community and health workers to go digital. The fear is just there, it's natural. We also have the problem of the product design challenges. People are not yet there. We still have a gap of training for people to get to know how to use these products. We also have low digital literacy among healthy workers and the communities. Yeah, still we need more training on that to make sure that our healthy workers and the community are all on the same page. We also have charges incurred while using the systems. These systems ought to be costly to some people, so that's why they run away from using them. But if they're made cheaper, then people are able to access them. Could you move to the next slide, please? Then I'll speak about the solution. Most importantly, the stakeholder involvement. We need the communities, the clinicians, the government, the policymakers to come up together and develop a joint strategy to make sure that everyone benefits from this. We also have to develop user-friendly tools just to make them simple for even the local person, an 8-year-old person to be able to at least access and use, so that they're able to see their doctors, since they are the underprivileged ones who cannot even move. So if these systems are made user-friendly, I think it's the way to go. We also need frequent training of the end users, advance the existing tools. We already have the tools, but if more technology has been added on the tools, then I think everything can be made better. We also have to do a routine technical support. We need to continue supporting this so that people are able to use without any disturbances. We need to build a national cloud system to ensure quality and create opportunities for the interventions when required. And also to adopt digital health standards. Very important. The next slide, please. My recommendations for future implementations, we have to have use of data standards for organizing, representing, and encoding clinical information so that the data can be understood and accepted by the receiving systems. Healthcare workers need to be adequately and continuously trained and empowered on the use of digital technologies. There is a need to consider the integration of interventions into existing systems, and also measuring and establishing the acceptability of the digital health interventions by healthcare workers and the communities in very critical and sustainability and scalability way. Heavy duty monitoring and supervision of both the health workers and the patients is very important and so much required. Routine technical support is very much required. Capacity building is required to ensure policymakers at all levels could use and interpret health data, and strengthening regional digital health systems, accessible, quality, and affordable digital health systems also. Thank you for listening to me. That's my last slide. Thank you so much, Dr. Derek. Thank you for listening from me. That is all I can talk about from Uganda via digital health.
Thank you so much. This was the voice coming from the Pearl of Africa, as it was mentioned by Dr. Joanne Nakimuli. Thank you so much for linking the two presentations, including the presentation from Dr. Suhail Juktai, who was talking about telemedicine and also included digital literacy, health workforce capabilities to engage digitally, what we refer to sometimes as digital determinants of health. Respected participants, we have one last intervention, which would be a video intervention presented by Dr. Hamadou Dia, who is a national coordinator for Sandy Digital Health Project in Mali. It will be in French. The intervention will be about digital health in the said project. Do switch to the simultaneous interpretation at the bottom of the Zoom screen, as the intervention will be in French. Handing it over to the technicians to play the video. And whilst the video is loading, would encourage speakers to take the liberty to respond in the chat for questions that were posed during your intervention. If you could take the time to go to the chat and respond asynchronously, that would be appreciated. While we're waiting for the video to load, just encourage once more colleagues to go to the WHO website. Telemedicine has been mentioned a lot here. It advances equity. WHO has guidelines on implementation of telemedicine provided to patients. So we encourage respected participants in this meeting to take advantage of the resources at the WHO website. The video, I believe, is loading, and we'll give it a few more minutes.
Bonjour à tous, très heureux d'être parmi vous ce matin pour participer à ce webinaire sur la santé numérique en lien avec les défis sur le continent africain. J'ai le plaisir de vous parler du cas du projet Santé digitale mis en œuvre par le Programme des Nations Unies pour le développement au Mali. Je commencerai par une petite introduction, ensuite je ferai le focus sur les
generalities or in general information on digital health. Briefly, I'll touch on Sandy project approach. I'll share findings and key results at the end. The COVID-19 pandemic has exposed more than ever the fragility of health systems, including those in low and middle income countries, as well as the
inéquité mondiale quant à l'accès aux services de santé essentiels, en particulier pour les personnes les plus vulnérables. À ce jour, on
estimated that around half of the world's population does not have access to essential health services. Digital health devices could potentially save human and material resources, resulting in more affordable, equitable, local, and quality health services. Now we talk about more affordable, equitable, proximity, and quality health services. Better access to digital tools and internet in remote areas would potentially break down barriers between rural populations, improve equity of access to health services, and reduce the vulnerability and level of discrimination of these populations. A study conducted between 2015 and 2018 in Mali has shown that online medical consultations cost 6 to 23 times less than in-person consultations, thus improving universal access to first-line health services. Collection and processing of health data is another advantage. The availability of data with the health information system allows government authorities to make more informed decisions based on priorities and issues exposed by data collected. Another advantage is more resilient offer in crisis situations. As such, digital health and telemedicine tools have demonstrated their usefulness during the COVID-19 pandemic to face challenges posed by cessation of in-person services, the lack of staff and/or travel limitations, both in so-called high-income and low and middle-income countries. Another advantage is improvement in the training of health workers and the services provided. The development of digital health also has potential to improve the knowledge and practices of health personnel, particularly in rural areas, by supporting training, supervision, access to information, and intra-communication professional in the field of health. Digital health, by offering more opportunities in rural areas for health professionals, also enables the retention of the medical profession in remote areas. I cannot talk a lot about the advantages, as there are also a number of difficulties involved in Africa in the context of digital health. First difficulty is interoperability, little taken into account. The overall failure rate of digital health products is 46.5%, which is half of the product. Another difficulty is inadequate regulatory framework. Governments wishing to implement a digitized health system must also establish standards that govern these practices, because they can have a significant influence on the security, safety, confidentiality of data, as well as on issues related to the consent and privacy. Another difficulty is work overload and failure of digital expertise among healthcare professionals. The low level of digital literacy of medical staff also makes the use of digital tools and their maintenance difficult, particularly considering the frequent absence of technical staff. A study conducted in Mali demonstrated that the number of working hours increased significantly on average from 41.9 to 58%, 58 hours, pardon me, when health workers were asked to enter data into a mobile application in addition to paper-based data collection and reporting system. Another difficulty is restricted access to an internet network. To enable data exchange, internet access is essential for digital health tools to be used. On average, only 45% of individuals in low and middle income countries have access to the internet, and in least developed countries, this proportion is only 20%. Another big difficulty in this context is access to sources of energy. Many countries in Africa face this difficulty in developing digital health. Another difficulty is initial investment costs involved in digital health. There are high costs involved needed for such programs. I'll talk about the approach of this project briefly. A critical mass of 5% of existing CSR, EFCS firms and ASCs are equipped with solar energy and telemedicine solutions and have the capacity to operate in a sustainable, cost-effective manner. This was initiation process from 2020 to 2022. Later, the scaling shows that between 2023 to 2030, all these agencies are equipped with will be equipped with solar energy telemedicine solutions and have the capacity to operate in sustainable and profitable manner. Universal medical coverage will be achieved. Vulnerable groups throughout Mali are actively engaged by then in improving resilience to shocks and promoting a local green economy. This is how it will be contributing to resolution of SDGs by 2023, particularly SDG 3, good health and well-being, SDG 7, clean and affordable energy, SDG 8, good jobs and economic growth, SDG 10, reduction of inequalities, etc. This project is getting a lot of traction and support from the government of Mali as it aims to provide universal health access to the local population, which is a priority of the government. Key findings of this project pertain to a number of issues related to better patient care, help with diagnosis and prescription is expected, an increase in revenue for especially pharmacy, laboratory, and admission office is also expected. The availability of quality data also improves with this project. Telemedicine, reduction of referrals and cost of care are also managed better. Better follow-up of third-party pairs is also expected.
Sur l'extraction automatique des indicateurs à partir du dossier médical informatisé. Et il y a également le volet télémédecine qui est inclus dans le programme qui permet vraiment de diminuer les références et aussi les coûts des soins. Et nous avions aussi un meilleur suivi des tiers payants, les différents tiers payants avec les systèmes de facturation automatique. On peut facilement générer leurs données et procéder au paiement de ces tiers payants par les services bénéficiaires. Donc, toujours dans
More findings show there'll be better commitments from certain AS, SDOs, and DTCS. Weak infatuations in places are found about this project. There are technical problems involving solar energy and network issues. There are long queues involved, and a lot of reorganization is needed for the success of this project. Communication with the community will be a factor involved as well.
Nous avions aussi constaté quelques petits problèmes techniques, notamment liés aux équipements solaires, surtout pendant la saison des pluies, où les problèmes de charge pour la source d'énergie persistent par endroits. Nous avions aussi détecté des petits problèmes liés à la qualité du réseau téléphonique et même à la disponibilité de la connexion Internet. Donc, dans ces zones, on a été obligé de renforcer les installations solaires et d'utiliser des connexions satellitaires pour pouvoir exécuter nos activités de santé numérique. Par endroit, le grand souci, c'est les files d'attente au niveau du bureau des entrées ou au niveau des box de consultation dû à la lenteur des agents, parce que tout ça, c'est un peu nouveau pour eux. Et dans certaines structures, ça a aussi nécessité une nouvelle réorganisation du travail parce qu'il n'avait pas d'agent dédié, par exemple, pour enregistrer les patients ou un agent dédié pour la pharmacie ou le laboratoire. Donc, l'informatisation a quand même permis de réorganiser un peu leur façon de travailler pour pouvoir atteindre leurs objectifs. Le dernier constat, c'est aussi la communication avec la communauté bénéficiaire, surtout en milieu rural. Quand on parle d'informatique, quand on parle de santé numérique, c'est très nouveau pour eux. Donc, nous avions aussi mis l'accent sur la communication directe avec les communautés bénéficiaires pour les expliquer les avantages et les défis des nouveaux outils qui sont mis à leur disposition. Enfin, je finirai par les résultats.
At the end, we'll give the key findings of the project. Digital Health Strategic Plan is one of the key outcomes. Establishment of PNCSN is another key result. Analysis of the regularity framework is another one. Then we have strengthening national telemedicine infrastructure. electrification and computerization of 21 CS-COMS, 7 CS-REFs, orientation and equipment of learned societies on telemedicine, orientation of more than 400 health workers on digital health maintenance of solar and computer equipment, and IPC is expected. Social protection, AGR with associations of women, young people, and IDPs is going to be another key result.
Sur les questions de maintenance préventive des équipements informatiques et solaires et sur la prévention et le contrôle des infections avec focus sur COVID-19 et aussi des activités de protection sociale comme des activités génératrices de revenus pour les femmes, les jeunes et les populations déplacées internes parce que le Mali, c'est quand même un pays en crise sécuritaire depuis 2012. Nous avons beaucoup de populations vulnérables qui sont incluses dans ce programme. Donc, je suis à votre disposition pour d'éventuelles questions. Je vous remercie.
Thank you for your attention. Are there any questions?
All right. Merci beaucoup, Dr. Dia, for what presentation. Thank you very much, Dr. Dia, for the video presentation. Just to thank all the panelists for their intervention. We have managed to catch up on panelist time. In a way, we now move towards listening to some interactive discussion, questions posed to the panel, and then I will allow some interventions that will be based on the comments that are in the chat. So as we go towards the remainder of our session, in the next 14 minutes or so, we'll have a directed intervention with the panelists. And we'd like to maybe begin with Dr. Dia, given that he gave a video presentation, to respond to a question. We do have Mr. Ba, who will translate Dr. Dia's response from French back to English. So I will pose the question to Dr. Dia. He will respond in French, and then I'll give the floor to Mr. Ba to translate the response. Dr. Dia, je vais commencer par une question pour vous. The questions are in anglais. The question is like this. You've given us a good video on your project in Mali. Could you speak to the audience here how you prioritize issues that are being faced in Mali using digital health? So how do you prioritize issues being faced by digital health in Mali? Your prioritization of issues being faced by digital health in Mali. Dr. Dia, vous avez la parole. The mic.
Ok, merci beaucoup, Derek. Donc, si je comprends bien la question, c'est quelles sont nos priorités au Mali en matière de digitalisation du système de santé.
Docteur, je peux vous apporter des précisions sur la question.
Ok, docteur Ba, allez-y.
Voilà, ce qu'il veut, c'est dire que tu as identifié tous les défis qui se posent au développement de la santé numérique au Mali. Comment vous allez prioriser les résolutions? Quels sont les défis prioritaires que vous devrez résoudre? Donc, c'est au niveau des défis, comment vous allez les prioriser à vous?
Ok, merci beaucoup, docteur Ba. En fait, déjà au Mali, c'est vrai, dans la présentation, je fais ressortir certains défis. Donc, à la date d'aujourd'hui, le principal défi pour nous, c'est vraiment de pouvoir aller vers l'informatisation globale du système de santé au Mali. Et pour nous, côté système d'information sanitaire, nous sommes assez bien avancés avec l'implémentation du DHS2, mais le problème de rapportage est quand même un peu partout. Donc, notre approche est vraiment de pouvoir aller vers une informatisation complète du dossier patient informatisé qui va vraiment permettre l'extraction automatique des indicateurs et aussi d'utiliser des outils qui sont surtout adaptés au contexte local à cause de tous les défis énergétiques et de connectivité. Nous sommes aussi en train de travailler sur le cadre réglementaire parce qu'il y a aussi un vide juridique par rapport à tout ce qui est réglementation de l'utilisation de la santé numérique au Mali. Donc, nous sommes en train de travailler sur des textes qui vont quand même réglementer l'exercice de la santé numérique dans notre pays. Merci.
Derek, I will summarize. Dr. Dia, think the first challenge are to develop and generalize electronic medical record at all the health facilities, the first priority. The second priority is to develop the legal framework. The legal framework also is a big issue at Mali level. So are the two issues that they will address with Sandeep project in Mali. Thank you.
Okay, merci beaucoup, Mr. Ba. Merci beaucoup, Dr. Dia. Thank you very much for the intervention. Let me just pose two quick questions to the panel, and then I'll open it up for the floor. These questions are very general. We've heard a lot of, hype around digitalization in COVID-19. We're living in the SDG era. So how can we put this together? How can we leverage digital technologies to fast track the SDGs, universal health coverage? I mean, what should we be doing to really put this all together to fast track our SDGs? And I'll be looking to you, Joanna, for Ghana, if you are able to take the floor, but also Dr. Sunhel, you talked about universal health coverage, and telemedicine is quite critical to really make sure we're not leaving anyone behind. 1 minute each, your reflections on leveraging this for universal health coverage, reaching the marginalized and so forth. Any of you can start under a minute, and then I'll open the floor to the audience.
Okay, so I will start. And thank you, Mr. Munene, for the question. I think we can leverage on the digital health technologies to help in future occurrence of a pandemic, or even currently, to help promote healthcare system. And one of the key things is to invest in training. I believe training is important. If we have the system set up and the people manning them do not have the adequate knowledge, it will be underutilized. In the same way, the patients or citizens going to receive healthcare, they also need some knowledge, literacy, technology literacy. And so training is important. Institutions, we can just break it down to the lower level of education, to the tertiary level and the higher level. Let everybody understand some of the basics in using some of these systems. This will help us to leverage and exploit the full potential of the digital health systems. So my take is training. We need to invest in training.
Thank you so much, Joanne, for that response. Digital determinants of health, as we call them, are critical. Dr. Sunhel, your reflection in particular, if you could also, as you reflect to universal health coverage, also just tiptoe around future trends that you foresee, which might not be popular, but might be useful for African countries. If you could combine those two responses under one question. Over to you, Dr. Sunhel.
Thank you, Mr. Munene. Really appreciate the question's nature, because it really addresses the issues in Africa. I give you an example of what we managed, how we managed in Pakistan. We connected the basic health unit in small villages and towns where there is no specialist by providing the nurse a tablet or using their existing tablet. And using that tablet, she was able to connect to a specialist in the tertiary hospital. So a child who's not well, needs a pediatrician, can be seen in the basic health unit through that special link. The problem was the internet bandwidth. So I went back to my software and chopped the bandwidth to 356 kilobyte per second upload. That means it's like a Netflix technology. And 3G signal, if a phone has a 3G signal, 2 bars, through a 356 kilobyte will be uploaded, so the patient's consultation data can go on the server, and then through a local node in Pakistan or wherever country we go, we can have 0.5 second latency to really see it live on the doctor's end in city. So in 5.5 second latency, you can have a 720 pixel screen, like a DVD quality, in a small area where there's only 3G signal. That means we can transmit ultrasound scans, ECGs, heart rates, and etc. to make critical decisions. And that will save the patient who requires a specialist but needs to travel, and they cannot travel. So this solved a major problem. And the population of Punjab is 110 million people. So we piloted that in Punjab along with the health minister, a project called Sehat Online. And that pilot was highly successful. So we are going ahead to go for further extension of the program. I hope that answers your question for Africa as well.
Thank you so much for those two interventions. Again, the digital determinants of health include connectivity, including access to bandwidth. And so really getting connected is quite crucial for us to achieve UHC, but at the same time for us to leapfrog digital technologies. One more question perhaps to Mr. Adeni Folayan. You did drop your intervention in the chat. Putting this all together requires policies. So maybe under a minute, if you could talk to us about your reflections on whether policies for digital health specifically exist in most African countries. You did talk about the numbers in your presentation, but if you can actually speak specifically, how do we transition from strategy to policies, transition from intention to actual policies? I know countries like Kenya have developed a policy on digital health. And so, but we need more policies that look at legislation of protection of patient data, confidentiality, and things like that. Your brief intervention, Mr. Daniel Folayan, on this question, under 30 seconds, if you're able to.
All right. Thank you, Mr. Derek. Basically, like I said in my presentation, what must happen is that different or various African countries need to consult or to conduct needs assessments. Yes, these policies are needed. Just like Joanna said from Ghana the other time, that data can be hacked. Data is not saved. Okay, data is not saved rather. So it is important that countries would need to conduct needs assessments and see, do we need these policies? Yes. And of course, we need to invite Africans with track record to build these policies from start to finish. Most of the policies we have were developed by Western experts. And of course, somehow some of these policies are not really working for us. So we need African experts with track records to help out on some of these policies, having conducted needs assessment by individual countries. Thank you.
Thank you so much. Thank you so much for the reflections. In the remaining time, let me turn to the respected participants. We can maybe have one or two questions from the participants. I did see a hand from George. If you could raise your hand for a quick question, for a quick intervention as we go towards wrapping up. I did see a hand from George. Do you still want to take the floor?
Yeah, thank you very much. And my commendation to all the presenters. My question relates to quality assurance. How do we protect patients from quack doctors, fake doctors who would want to capitalize on virtual health to cheat patients?
All right, very good question. And maybe let me turn to Dr. Sanhiel for that question. Over to you, under 30 seconds, if possible.
We have devised a system where doctors' credentials are saved on biometrics. So we provide the biometrics USB kit to the doctor, and only those who are provided, they can see a patient. Number two, we have a system where we have 30-second recording of the video consultation as a snapshot, which is saved as a credential check, that was it the same person who actually registered. And third thing is time-to-time checking. And also at the same time, we do mock patients, like who can just go on the website and see whether they meet the right doctor or not. But usually nowadays, people are very conscious, and it's very easily trackable, because we can track the IP address where the consultation is being made from to track to the location where there was a fake doctor, if there was.
All right, thank you so much. Under 30 seconds, Dr. Joan Dudu.
Okay, so thank you. With regard to the question, I think it's very legitimate And so what we can do as countries is to have a policy that monitors the implementation of these telemedicines or technologies. And so just as you need a license to practice, we can translate it to that aspect so that if you want to operate in digital health, provide digital health services, you will need a license to do that. And this will help us monitor and also ensure that there is quality in the provision of healthcare.
All right, thank you so much for those two interventions. We have unfortunately come to the end of this robust session. I'll provide a few remarks and I'll call Dr. Farid for a closing. Just to maybe thank respected participants that came to this meeting, but also to thank the panelists.
I think we have a speaker, Miss Jamola. She is here. So you can to her as well.
Oh, my apologies, my apologies. Yes. Let me then attend to Miss Jamola. I did not realize that you were still there.
Are you here?
Yes, I am.
Yes, she is here.
Okay, all right. I must give you my apologies. I thought that you had left. Your question actually is quite important because it focuses on the enabling environment, cooperation between ICTs and health.
Hello?
If you could give us your reflections. Hello, are you there? All right, if you could give us your reflections.
Sorry, I didn't hear the question.
Okay, all right. I'll ask the question briefly. If you really can tell us what you think your current IT structure, for example, in your country, do you think that your current IT structure in your country is capable enough to support large-scale use of digital technologies to achieve universal health coverage? Your reflection around your readiness to achieve UHC, given the IC infrastructure in your country. Over to you.
Okay, thank you, Mr. Derek, and thank you to all the presenters and the participants for staying on. Currently in Nigeria, the current IT structure is not fully capable to support large-scale use of digital technologies to achieve UHC. However, with some of the initiatives that we are putting in place, like when we adopted the ISO TC 215 on health informatics, the work being done by the Federal Ministry of Communications and Digital Economy to ensure that there is the right infrastructure, not just in the urban areas, but also cover the underserved and the unserved areas, such that digital health, digital services across all sectors can get to the common man at the last mile so that they can use these services. But right now, as we speak today, the 7th of December, 2022, 100%, no, we cannot support. We need to build more. We have a broadband policy, which we are leveraging on to implement to ensure that broadband gets across the whole country and everyone can get access to digital services that they need. I hope that answered your question succinctly.
It did, and just to reemphasize the importance of the ICT sector, and your intervention has been very critical, and others can learn from what you just described. All right.
Thank you very much. I have to leave. I have another meeting. I do apologize.
Thank you so much, actually, for staying on, and we are now wrapping up. So, would want to once again bring the session to a close. I just want to thank all the panelists, all the respected participants that came to this session. There are a number of points that have come on the discussion around the digital equity or achieving equity using digital, so telehealth, virtual care, the regulation environment, using policies to inform the implementation, including digital literacy. Key issues around the future of digital innovation using AI have also been discussed. Would like to appeal to all the participants to really influence the agenda of digital transformation in this era of COVID and indeed post-COVID. The new normal is digital. Let's invest in the enabling environment. Let's invest in scale. Let's invest in closing the equity gap so that we leave no one behind. Thank you so much. It's been a pleasure for me to moderate this session. I'll hand over the virtual floor now to Dr. Farid. Over to you.
Thank you, Derek. And you have been very kind to give this time to us, and you have done a wonderful job. And as you have summed up very precisely what we had learned this evening. And we hope that I would like to thank you, our speakers and all our participants who gave their time for this event from the platform of this COMSATS, and we wish that we can continue such activities. And actually we have been we are trying to create a network of our COMSATS member countries and other developing countries, some sort of network of this digital health that can help us keep connected. By the way, I think we had Dr. Najib Al-Sharbaji with us. Is he still here? Dr. Najib, sorry, I forgot you were present here, and I wanted to hear something from you. Any comments?
Yes, I'm here. I'm listening all the presentations. I have just actually